All right, why don't we call this meeting to order? Welcome, welcome, welcome to the DORR Breakfast. This is very exciting. We're thrilled to have everybody here. I don't know how many people we have that are also watching on Zoom, but this is the topic of interest to everybody. So we're thrilled that everybody is here. The DORR Breakfasts are community educational workshops. Everybody is welcome. We send press releases out. We invite the community to come and join us because we're here to learn. That's one of the missions that one of the things in the DORR mission statement is to educate the community. And that's what we're trying to do today here. I want to introduce myself. I'm Ellen Ferreira. I am the brand spanking new president of Democrats of the Verde. And the very large shoes of Kathy Rutherford, who preceded me. She's wonderful. And so this will be a challenge and a lot of fun. The vice president of DORR is sitting over here, Diane Christensen. So thank you so much. We have lots of members here. And if you're not a member, you can certainly join out front if you're so inclined. We've got Josh Tinkle, who is the acting CEO of Northern Arizona Healthcare, as you know. And on the screen, on the Zoom screen, we will be zooming in with Stephen Zuckerman, who is with the Urban Institute. So we're planning to have all of our upcoming meetings both on Zoom and here live in person, but to you Zoom people, it's a lot more fun being here. We have food and exciting things going on, and it's very nice to be here in person. DORR is an organization that is completely run by volunteers. If you are a member and you have a skill or had a skill in your previous life or a talent or something you enjoy doing and you would like to bring that skill to DORR so that we can help maximize your interest in the world and your talents and skills, please step forward and let us know, because we can use you no matter what you do. Anything from baking to phoning to researching, whatever you want to do, we'll find a place for you. We have a film club that meets once a month, and you should get those notices in the mail. They're interesting films and interesting discussions. We've got a lot of fun things coming up, including a Oak Creek Canyon cleanup. We're going to join with the Verde Valley watershed or the Oak Creek watershed, I'm sorry, and do some cleanups there. We've got lots of activities. So when you get those DORR notices, please open them up. Don't think they're just junk mail. They're not, and we're not asking you for money, but if you want to give them, we're certainly not precluding that. I wanted to introduce Margaret Connery. Margaret is in charge of our events committee. And when you hear her speak, you'll know exactly why she's in charge of our event committee. Margaret, you want to come up? You want to take a minute?
Hi, everyone. You know, we work really hard in Democrats of the Red Rocks to achieve goals and to educate ourselves and educate the community. And so when you're working that hard, you need to have some fun. So I'm here today to talk to you about fun. Okay. We are going to participate in the
Halloween.
But before that, we're going to participate in the St. Patrick's Day Parade in Uptown Sedona on the morning of Saturday, March 18th. And we are going to have a lot of fun doing this, and we need a lot of people to help us have that fun. We are going to have a float. We're going to have walkers and riders in the parade. We're going to have giveaways for the crowd. And so for this, we're going to need people to help plan the decorating of our float. Our float will be Diana Christensen's very nice big truck. So we'll use that for our float. We need people to help plan the decorations, people to show up the morning of the 18th to help decorate. And then we need walkers and riders in the parade. Now I'm going to do a little skills assessment here. I want everyone to put up your right hand like this and go like this. You are qualified. Okay, we'll see you on the 18th. We're also going to need people to help assemble our little giveaways, which will be little envelopes with wildflower seeds in them. And they'll have our really nice new DORR logo and some information about our organization. So my email, write this down if you're interested at all. My email is margaret.connery@hotmail.com. I'm the only one you know who still has a Hotmail account. Margaret.connery@hotmail.com. I will also be here today after the meeting and you can talk with me then. So I hope you'll join us for the 18th.
Thank you.
And Josh Tinkle asked me before if this group was fun.
This group is fun. That is good. Speaking of fun, it's not too early to sign a petition. You can almost know that if you're here, it's petition signing time. Only if you are so inclined. We have petitions to get Congressman Ruben Gallego on the ballot to run for Senate in 2024. So I'll circulate these together. Please read at the top of these. There is one for Yavapai. There is one for Coconino. Please sign the appropriate petitions with and also, this sounds silly to say, but stay in the lines. This is more important than you would ever believe. Penmanship counts when it's signing these petitions. Please stay in the lines. Okay, today we're focusing on healthcare, and this room is full because everyone cares about healthcare. I've just been through an ordeal with my father in Florida, and the healthcare system, it was very difficult to navigate there. And my strongest advice to everyone here is to stay healthy. That means do not get on ladders. Do not climb on your roof to try to get the DirecTV thing. Do not text while you're driving. The most important thing you can do is just to stay healthy and try to avoid the healthcare system entirely. No offense, John. But this is not where you want to be. And so do the right things. Prevention is the most important thing. This is an educational session for the community. This is not a roast. We all have. You
can roast me though if you like.
We all have personal issues. We have grievances. We have things we'd like to discuss with somebody from the NAH. This is not the time to discuss your personal matters. Believe me, he does not know your billing problems, and he doesn't need to know them and shouldn't know them. He has bigger things on his mind. So please, when you ask your questions, and we will have time for questions, make them of a general nature so that they are interesting to everybody in the room and everybody watching. Our first speaker is going to be Stephen Hanks. Stephen is the new program chair and will be setting up the agendas for the upcoming breakfasts. If you have ideas or suggestions that you think would make good breakfast topics, please let Stephen know, and info at Red Rocks, of the Democrats of the Red Rocks will work. You can get in touch with any of us that way. And Stephen will introduce our program and run with it.
Thank you.
Thank you.
Hey, guys. So first I want to, she's gotten a lot of these so far, but I want to congratulate Ellen Ferraro again on becoming the new president of DORR. I also want to thank her immensely for giving me finally an excuse to wear a tie in Sedona. Where's Linda? See, Linda laughed when she saw me. And I said, you know, you're supposed to wait until I tell the joke before you do that. But by the way, you should all congratulate yourselves because I found out a little while ago that the parking lot is full. So I hope the people that did not have a space in the lot can park somewhere because we want to get everybody involved in this as we can. Okay, so a little bit about healthcare before I introduce my first guest. As we are all seeing, based on the, as short time ago as the State of the Union, healthcare is going to be the issue. Now, it's hard for me to say that because back when I was in New York before the 2018 elections, I was hosting cabaret fundraisers to raise money for Democratic candidates. And my big issue that I would always talk about was voting rights. Because as far as I'm concerned, everything else flows from that. Every other issue that we're concerned about. Now, what surprised me about the 2020 midterms was that the 2022 midterms, excuse me, was that in spite of the fact that Democrats did really well, I mean, we kept the Senate, we won the president, we almost won the House. I think we might have won the House if candidates had done what they did before the 2018 midterms, which was constantly talk about healthcare. That's what won 40 seats for Democrats. For some reason, before the 2022 elections, and abortion obviously was the big issue. But abortion, to me, falls under the rubric of healthcare. But we weren't talking about any other healthcare issue. We weren't talking like we're talking now, or like Biden's talking now, about the threats to Social Security, Medicare, and Medicaid. So that's got to be issue number one going into the next election. And I think if it is, we'll do pretty well. On that note, my segue is going to be to introduce our first guest. And this is a particular thrill for me because Steven Zuckerman, in addition to being fantastic healthcare expert for the Urban Institute, who specializes in Medicare, Social Security, Medicaid, all those issues, we also worked on our college newspaper together in New York. Steven was a year ahead of me, and maybe even 2 years. He'll probably correct me. When he was editor-in-chief of the paper, I was a sophomore. I was sports editor, and watching Steve at work, he became my mentor, and I eventually became editor-in-chief of the paper. We've been friends ever since, and I'm happy to say I was the best man at his wedding. So it's a thrill for me to have him as a guest today. Let me get my reading glasses here, which I hate. So I won't go through the whole list that was on. Oh, okay. So he's a VP and senior fellow in the Health Policy Center at the Urban Institute in Washington, D.C., which is a nonpartisan think tank. I need to stress that. Steve is here as a nonpartisan actor. He's studied health economics and health policy for 35 years. He's a national expert on Medicare and Medicaid physician payment, including how payments affect enrollees' access to care and the volume of services they receive. Stephen is currently focused on exploring the effects of the COVID-19 pandemic on family health and well-being using data from 2 internet-based surveys of non-elderly adults designed by the Urban Institute. He's published numerous studies on hospital finances and Medicare Advantage, health policy research, and he received his BA from Herbert H. Newman College in the Bronx, part of Kingston University of New York, and his PhD in economics from Columbia. It is my pleasure to introduce to you Steven Zuckerman.
Thank you. So the fact that he was the best man at my wedding, I'm not going to hold that against him. I'll let that go. And the fact that he was inspired to wear a tie in Sedona, I'm not inspired to wear a tie in public. So when Steve asked me to speak today, you know, speaking about health policy, someone who we don't normally like to talk about in the prior administration said, you know, health policy can be very complicated. And that quote is in my office on a bulletin board. So I wanted just to start the conversation, talk about 2 issues that are going to be pretty important in 2023. and probably going into 2024. Steve alluded to one of them, which I'll come back to in a minute, some of the issues around Medicare financing that were brought up in the State of the Union. But the first thing I want to talk about relates to Medicaid. And Medicaid's program that covers a lot of low-income people and is sort of at the foundation of the Affordable Care Act. And when the coronavirus pandemic hit in March of 2020, there was a lot of panic about people losing jobs. And since a very large percentage of people in the United States have their health insurance through their employer, there was concern that there really needed to be a backup plan, and fast. So Congress in March of 2020 passed the Families First Coronavirus Response Act. And what that did is it gave states a lot more money to finance their Medicaid programs. Medicaid is a state-administered program that's financed largely by the federal government for low-income populations. And in Arizona, for example, before the pandemic, about 70% of the costs of Medicaid were picked up by the federal government. After the response legislation was passed, that was increased to close to 76%. So there was a large influx of money to support the Medicaid program. But there was one condition. The condition was that during the public health emergency that the coronavirus created, states could not disenroll anyone from Medicaid. So what that meant is that anyone who was on Medicaid in March of 2020 had to stay on. And anyone, either because their income fell or for other reason, who qualified for Medicaid between March of 2020 and whenever the public health emergency was going to end, could not be disenrolled from the program. There was no eligibility considerations. Once you were eligible and enrolled, you stayed on the program. So what did that mean? Well, it meant that nationally, from about 60 million people being enrolled in Medicaid in March of 2020, there are now 78 million people enrolled in Medicaid. And in Arizona, to put that in perspective, there were about 1.7 million people enrolled in Medicaid in March of 2020. There are now about 2.2 million. So about 500,000 people in Arizona are now on Medicaid who weren't on Medicaid in March of 2020. And that's about 300,000 adults and about 200,000 children. Now, everyone was waiting for someone to say the public health emergency is over. And no one has quite said that yet, although I think they're projected to say that in May of 2023. But when the public health emergency was over, states were going to have about a year to 14 months to figure out who was still eligible for the program. And that's called the Medicaid unwinding. Now, that's going to be a big deal for Medicaid. It's going to be a big deal for states. You would think it would be a big deal for the people who are currently enrolled in Medicaid, but some national surveys that we've conducted at the Urban Institute indicate that about 62% of the people who are currently on Medicaid are not aware that this is happening. And another 16% have only heard very little about it. So this is going to be something where a lot of people could get disenrolled from Medicaid because states don't know how to contact them after all this time. They may not provide the information that the states require to figure out if they're still eligible, and that can lead to a lot of people losing coverage. And some estimates that we've done is that about close to 4 million people nationally could lose coverage and become uninsured. Now, some people will have gone back to work and gotten employer coverage. Some people will be eligible to buy coverage through the ACA marketplaces. And some people will still be eligible for Medicaid if the system for redetermination works, but some people will become uninsured. And in Arizona, our estimates suggest that about 125,000 people could become uninsured. Now, a lot of the healthcare providers in Arizona are not going to like that. And a lot of the people who are currently on Medicaid could really have some serious problems getting the healthcare that they need if they become uninsured. And that's I really think going to be one of the central issues that may not be front of mind for a lot of people, but it's going to really dominate, I think, state health agencies and Medicaid agencies during 2023. So that's one thing. And the public health emergency, when was the public health emergency going to end? Well, while the administration was thinking about ending the public health emergency, Congress passed major budget legislation in December, and they decided, you know what, enough. We're going to decouple Medicaid from the public health emergency, and April 1st, all these Medicaid provisions are over. And gradually, the extra money that states have gotten to support this higher enrollment in Medicaid is going to diminish over the course of a year. So little by little, the increase in the share of the program that the federal government is paying for is going to start to disappear. And I think that's going to be something that is going to be worth watching to see how well states administratively, who are going to be challenged in this situation after all this buildup of enrollment, how they actually deal with that. So that's one topic that I wanted to touch on. Second topic I want to touch on, Steve already alluded to, and the State of the Union brought it up. It came up in the State of the Union pretty prominently. So the actuaries that monitor the Medicare program have projected that the Part A trust fund is likely to become insolvent in 2028. What that means is that what Medicaid pays providers on behalf of beneficiaries will have to be cut in order to stay within the available funds. Now, this may sound like a big deal, and it certainly is something that has to be focused on, but it's not the first time this has happened. Throughout the history of the program, going back to 1965, there's always been this pending insolvency, and policymakers have always figured out ways to change payments, change the way they tax people. Now, if anyone paid Social Security taxes, there's a limit on the amount of income that gets hit with a Social Security tax. There's no limit on the amount of income that gets hit with a Medicare tax. So the Medicare payroll taxes get paid on all income. And as clearly the debate over this has already started in the State of the Union. Now, right now, there's a lot of different options, and I'm not going to try to cover the laundry list of options, but there is one area that I do want to talk about because it's become a major part of the program over the last 10 to 15 years, and that's Medicare Advantage, which are private health plans that receive a monthly payment on behalf of their enrollees to provide all required Medicare services and to have a cap on the amount of out-of-pocket spending that beneficiaries are required to pay. In traditional Medicare, what used to be the Medicare program and what gradually is becoming, a partner, if you will, with Medicare Advantage, there is no cap on the amount of out-of-pocket spending that people have, and it often leads people to buy supplemental coverage in addition to the Medicare coverage that they have to pay. And Medicare Advantage plans, I'm getting feedback.
Hold on, Steve.
Okay.
Give us a moment.
Okay, take your time.
Then it went away.
Okay, I think it's better now. Okay, so Medicare Advantage plans attract enrollees because they get paid a little bit more than they're likely to have to spend on their beneficiaries. That's the way the program works because there was a policy decision made that people should have a choice of private plans, and to encourage private plans to participate in every area of the country. At the beginning of these private plans in Medicare, the private plans could only really operate where traditional Medicare was very expensive. But about in the early part of the 2000s, there was a decision made that everyone should have access to one of these private plans. So the private plans began to get paid more than they were probably going to cost if the beneficiary stayed in traditional Medicare. What that means is that from about 1 in 5 beneficiaries being in one of these Medicare Advantage plans 20 years ago. Now, one of every two beneficiaries are in one of these private plans. And in Arizona, 51% of the people in Medicaid in Arizona are in one of these private plans. Now,
That's
38%
Medicare, yes.
Medicare?
Medicare Advantage. Yeah,
You said Medicaid. Medicare.
I'm sorry. That's, no matter how long you're doing health policy, it's easy to get those. Yeah, so Medicare, so 51% of beneficiaries in one of these private plans, about 38% of that 51% are HMOs, about 13% are PPOs. And I think among policymakers and analysts, there's a broad consensus that these plans are overpaid now, probably by about 4%. So there's some money to be had there. Used to be much worse than that. I mean, overpayments were in excess of 10 to 12%, probably about 10 years ago. Now, there's a lot, since plan payments are adjusted based on how many conditions the enrollees have and diagnoses, there's a very strong incentive for plans to really look very, very closely at beneficiaries' health records, and much more so than in traditional Medicare, where you go to the doctor with a cold or something or the flu, and your diagnosis is the flu. If you go to a Medicare Advantage, and you're in a Medicare Advantage plan, there's likely to be much more concern about incredibly detailed histories that are documented, and this tends to increase the costs of Medicare Advantage plans. There are other aspects of how these plans are paid that I'm not going to go into now, but there's already been some changes that are being proposed by the federal government for 2024. And if there's been some very harsh language just yesterday from the HHS Secretary, Javier Becerra, about the plans and their financial incentives. And of course, needless to say, the plans do not feel they're being overpaid. But, you know, if, so there could be changes that will occur just inevitably if the program is looking to save some money to stave off Medicare solvency. There's a lot of other choices that could be made around the size of the Medicare payroll tax, what income gets taxed. I mean, right now, only earnings are taxed. You could have unearned income that gets taxed. You could see payments to providers get either slowed down or frozen. There's a lot of options, but Medicare Advantage is going to be, I think, a central target. No one wants to talk about it. Democrats don't want to talk about it. Republicans don't want to talk about it, but someone's got to talk about it if the program is going to get on more solid footing. So I'm going to stop there, take questions, or if Steve wants to turn to the other speaker, I'm happy whatever you'd like to do.
And Josh will come on.
Yeah, so if anybody has a question for Stephen, go ahead. And then once we're done with that part, we'll introduce Josh. Go ahead.
I have a question. I was a little unclear on when the extra payments to the states are going to end, because you said maybe in May and then
No, they're going
to April 1st.
They're going to start phasing out April 1st. And I don't have the schedule right off the top of my head, but it's going to gradually, there was like a 6.2 percentage point increase in the share of the program that the federal government paid for. And that's going to gradually go down to 4%, to 2%, to 0% over, I think, the course of a year. It's going to gradually phase out over the course of a year, starting in April.
Steve, I have a question for you. To your good friend.
Okay.
Over the years, we've had a lot of discussions about the supposed ending of Social Security and Medicare as we know it. The last couple of days, specifically, I've heard Ron Johnson call Social Security a Ponzi scheme, and Mike Pence yesterday again talking about privatizing Social Security, that people should be allowed to get their own plans and the federal government not be responsible. This may not be as much a policy question for you as an opinion question, but what's your take on all this?
Okay, so, I mean, calling it a Ponzi scheme is a negative way to describe it, but it's definitely the case that the money is not, that people have paid in over their lives is not sitting in a private account somewhere with their name on it. There is this kind of rolling tax system, taxes that are paid that are used to fund the benefits. So, the current retirees funded previous retirees, and current workers are funding current retirees. Now, one of the problems, and this is a demographic problem, is that, a lot of us are part of the baby boom. And, demographers like to describe the baby boom as like, a grapefruit going through a snake, that bump. And, the problem is that there are fewer workers per retiree now than there were 20 years ago. And, that could mean that taxes on current workers have to go up if you're going to really balance the program, or you're going to have to borrow money and increase the debt to fund benefits. But that's in fact, that is in fact the issue. The privatization aspect of Medicare, of Social Security, I don't think that really works, because Social Security is a social insurance program. It's not an investment program. And the social in the concept of social insurance, it's going to be a societal effort. And people can invest their own money however they'd like in IRAs or other retirement plans, but the social insurance aspect of Medicare and Social Security is really, I think, fundamental to the program. It would really change the nature of the program dramatically if it were to become privatized.
I have one more for you on this topic. Has the Urban Institute done studies over the years about the feasibility of raising a retirement age, which a lot of the Republicans are bringing up as a way to save the program?
Yeah, we've done that. I mean, and basically, basically, the programs cost less. But like, let's say with Medicare, if you couldn't get Medicare until you were 67 instead of 65, but you were already retired, and you didn't have employer coverage, where would you go? You'd probably go to the ACA marketplaces to get coverage, and there would be subsidies involved to that. So exactly how it all balances out is, I don't have that off the top of my head, but you definitely would not just simply eliminate people from government roles unless people continue to work more. I mean, there are many people who are over 65 who are continuing to work and continue to have their employer plans. I know many of them. You're looking at one of them, some of my colleagues. But that's an option in Medicare. Now, obviously, if you retire and you don't take a full Medicare Part A and Part B, so the hospital and the physician, you end up paying penalties down the road if you enroll in Part B late. But if you have employer coverage, you don't do that. So I think that you could raise the age of eligibility for Medicare, but that'll have other implications, or generate more people who are uninsured, which is probably not a good thing for a 66-year-old to be.
Yeah, exactly. Anybody else with a question for Steve? Yeah.
So you mentioned that with the Medicaid Advantage, that they look at past
Medicare.
medical history. I'm sorry, yes, Medicare Advantage. Jeez. So as someone with chronic health conditions, that's very concerning to me, though I'm not yet of age to worry about that. Are there plans in place to make sure that people with chronic conditions don't lose coverage because it costs more?
Yeah, that's a good question. So because Medicare Advantage has become such a big part of the program, and because there are people with chronic conditions, there are what are called special needs plans, where the plans are really organized around being able to take care of people with more serious conditions. Now, even in a regular plan, if you have chronic conditions, that plan is going to get paid more for you than for someone who doesn't have those chronic conditions. But there are definitely special needs plans that are being organized. There are some people who, let's say, have sufficient disabilities that even before they're 65, they're eligible for Medicare, Medicaid, as well as Medicare. And so those and Medicaid and Medicare tend to cover different types of services. But there are now plans that are being organized to take care of those people who are dually eligible for both programs. So yeah, there's accommodations there. But I think with Medicare Advantage, what I always say to people is you have to think about if you've got serious health conditions and you've got a set of healthcare providers that have been caring for you for years, before you go into a Medicare Advantage plan, which could have a narrower network of providers and fewer provider choices, you have to think about whether the providers that you want to see are still going to be available to you. And that's a very individual choice. I mean, a lot of people talk to me about this, about the choices they make. And that's really what you have to do. You have to decide what you're comfortable with when you make these plans. And unfortunately, there are cost implications. I mean, some people can't afford to make the choices that might be best for their health care.
Josh, you got a question?
Yeah, I did. I mean, this is absolutely fascinating. What a great lead in to what we're talking about. I mean, I'd be curious on Stephen's perspective. He gets the pleasure of being able to think about how we solve all these problems. Stephen, I'm Josh. I'm the CEO of Northern Arizona Healthcare. I'm oftentimes trying to navigate, well, here's a set of rules we play by, right? And what's interesting to me about the US healthcare system, and I'll talk about this a little bit, is for all intents and purposes, the revenue side of our business is completely fixed. Medicare pays you what Medicare is going to pay you. Medicaid is going to pay you what they're going to pay you. But the expense side is extremely variable, right? So last year you have 9.2% in inflation. The federal government, recommends making a 4.2% reduction in physician payments, while at the same time, while the insurance companies have their greatest profit in the history of insurance companies, and hospitals are going to lose 70% of hospitals will lose money in 2022, right? So I give you all of those dynamics. I'm curious, Steve, at some point there has to be some normalization. All the expenses appear to be, at least from my seat, free market, right? Labor goes up, we pay more. Supplies go up, we pay more. Procedures go up, we pay more, but the revenue doesn't always come with it, right? And so I'd just be curious from a policy perspective, where does Stephen kind of see that going?
Okay, well, one of the things that has happened, I mean, first of all, Medicare rates do go up over time. They're not completely fixed. Medicaid, I think, is a problem, but a lot of states have worked out some supplemental payment schemes around Medicaid. One of the places that there's been dramatic growth in payments is from private health plans. I mean, right now, private health plans are paying hospitals roughly 240% of what Medicare is paying those hospitals. Oh, wow. And a lot of that has been driven by, and I don't know what the situation is in your health system, but a lot of that has been driven by very, very significant consolidation in the hospital industry and health systems buying up physician practices. So the consolidation in that market has allowed providers to really negotiate much higher payments from some of the private health plans. And, I think there's no question that the notion that your expenses are fixed is something that a lot of health systems like to project, but expenses are not fixed. I mean, systems can adjust. It's not easy, but when going back quite a while, when Medicare adopted a DRG payment system where hospitals were paid a fixed amount per admission, so they had a tremendous incentive to get patients out of the hospital faster. Magically, they got patients out of the hospital faster in a very short period of time.
Right.
There can't be, it can't be that the system is completely fixed if in fact there's going to be any effort at containing costs. And it's a challenge. It's not easy. It's one of the reasons health economics is so interesting.
One more question for Steve. Go ahead.
Yeah. The complexity of the healthcare system is really hard for the consumer, and it's extremely costly because of all the middle management and manipulation. Do you ever see that being simplified So all the middle management, the private insurers that get paid a lot of money, the people that actually provide the healthcare and the consumers of healthcare are the focus, and there's not this great loss of money in the middle.
You know, that's a great question. And I absolutely agree that the administrative costs in the system seem incredibly wasteful relative to a lot of other countries. Right now, I mean, it may be sort of a discouraging thing to say, but, you know, with a private healthcare system, and, you know, we haven't even talked about private equity firms buying into the healthcare system, trying to figure out ways, you know, to skim off some of this excess revenue. It's there's no question.
All right, so Stephen's gonna stick around to listen to Josh and
Keep me honest.
and
I'll
things
ask some
being equal,
questions.
Since Josh had a question for Steve,
Yeah, I'm sure.
Stephen may have something, and also if you think of it. Who we're very happy to have here, and really appreciate that he took the time to be with us. So Josh Tinkle joined Northern Arizona Healthcare in 2019 as Chief Operating Officer of the Flagstaff market. And in August 2022, he was named Acting Chief Executive Officer of NIH. Prior to joining NIH, he led operations for Dana University Medical Center in Phoenix, where he was responsible for and I wouldn't know how impressive these numbers are, he'd have to tell me, 767 beds, level 1 trauma center, 27 clinics, and approximately 2,000 providers. His career in healthcare started in marketing and business development, and this work included more than 8 years with Unity Point Health, a hospital system consisting of 32 hospitals, 290 physicians clinics, and home care services throughout the Midwest. Josh earned his bachelor's degree in business administration management from the University of Iowa, and he confirmed for me that his favorite musical is The Music Man, which pleased me very much. And his master's degree in health administration from Des Moines University. And I also found this interesting. Besides being a fellow of the College of Healthcare Executives, he's also a Six Sigma black belt.
Yeah.
Wow.
Yeah, careful, yeah.
Ladies and gentlemen, Josh Tinkle.
Yeah. Well, one, thank you all for joining, and what a perfect tee up to healthcare and some of the challenges that we collectively experience. Can everyone hear me okay in the back of the room? Just to make sure my voice is carrying. I'm just an absolute pleasure, one, to be here and to talk to you guys a little bit. I'm going to take a little bit different spin. I'm going to talk more specifically about Northern Arizona healthcare and how we provide service or how we view service in our communities. But a lot of what Stephen's talking about, and a couple people mentioned it, the normal consumer doesn't see all of the complexities that we're currently dealing with. And so I apologize if you've seen this presentation before. I've been pretty consistent on my message since I took on the role in August of 2022. And our commitment here, specifically to the Verde Valley, we're talking about it, is we want to be your healthcare provider for years and years to come. And we haven't always done the best job of delivering that healthcare. And so I'm here to kind of talk through some of those. But I also want to lead a little bit about what is Northern Arizona healthcare. Stephen mentioned consolidation, and that is certainly happening across the country with Common Spirit and which is Dignity, and those hospital systems are getting larger and larger and larger. And I think there's a couple of different reasons for that. Stephen mentioned, some of it's consolidation to negotiate with insurance companies, some of it's consolidation to help with expense management. Northern Arizona Healthcare is a not-for-profit healthcare system, and I think that's really important for people to hear. There are some in the community that think, oh my gosh, they're all about the profits, and all their profits are going to shareholders. And what I mean by not-for-profit, and hopefully Stephen will echo this, doesn't mean that the healthcare organization doesn't need to make money, right? So what it means is that we don't answer to a bunch of shareholders who say, drive profits, drive profits, drive profits. Any excess revenue that we have over expense, we take and reinvest in our labor, so our workforce, programs that maybe don't generate positive excess revenue, and then infrastructure from a capital perspective. We have a little over 3,000 employees, so we're considered a pretty small healthcare system. We consist of 2 hospitals. We have one in Cottonwood, one in Flagstaff, a host of ambulatory clinics, et cetera. And we have ERs that are open regardless of anyone's ability to pay. Last year alone, as you'll see on the next slide, we provided about $125 million in uncompensated care to the region. And as we talk about levels of service, some people have heard this before, and so I got some really good feedback before. I'll try to simplify it a little bit. But what we're blessed to have in Northern Arizona is a level 1 trauma center. So I'm going to ask real quick, and if you've heard this before, you can't answer. How many level 1 trauma centers do you think there are in the state of Arizona?
2.
2, 5, 13.
And most of them.
Yeah. How many are in Phoenix or Maricopa County?
12.
11. Right? Okay. So when you think about that, you have a concentrated area, and Korean, they have a lot of population, but they have 11 level 1 trauma centers there, and then you have 1 in Tucson and 1 in Flagstaff. And why is that important? A number of years ago, there's something called Prop 202 that you guys may or may not be familiar with, but it takes gaming revenue and reinvests in level 1 trauma centers. And so one of the beautiful things, as Stephen's talked about, we do what we're incented to do. You talked about DRG payments, all of a sudden we get patients out faster, right? We're incented where the dollar is. And what Prop 202 did is it took the gaming revenue and it helped subsidize level 1 trauma or tertiary level care. Well, what do you do if you have another bucket of money to get? You start putting level 1 trauma centers on every corner, like the Starbucks, right? And so what we're fortunate to have, though, in a rural region is a level 1 trauma center. And we'll talk about that and why that's important and why you even care about that down here in the Verde Valley. So again, we're a not-for-profit healthcare system. We are here to meet the needs and delivery of care in the community. 25% of all the patients that we take care of are considered financially disadvantaged. We're the sole community provider in Northern Arizona from a hospital perspective. About a third of the patients that end up at Flagstaff Medical Center are from tribal nations. So we service about a 50,000 square mile kind of chunk, and we have about 700 to 800,000 lives. I know that sometimes we'll put 1 million up. I don't think it's quite that many in that region. And we service that, which is a little bit different than where I'm from in Iowa. And I'm not sure, where was Stephen from? New York, a little different than New York. Even in rural Iowa, you have a lot more infrastructure and hospitals closer together. So you, in Northern Arizona, you may go hundreds of miles without having a critical care access hospital, a clinic. And so we do that by aircraft. So we have about 10 aircraft that we service the region, getting people to the level of care that they need. So when I first started having this talk, it was really starting to divide out what is healthcare and what healthcare needs do we need in our community. I'm from a small town, Grinnell, Iowa. It's a population of 10,000. The college is like 4,000 of that 10,000. So a very small rural farming community. And so when you start to think about our region and what do we need for healthcare there, I think it's really important to start to talk through what are the various levels of care. And when we talk about continuing or maintaining and expanding services in our region, what does that mean? So I'm going to go through the technical terms, and I'm going to try to simplify it as some of our feedback suggested. So there's really 4 levels of care in healthcare: primary, secondary, tertiary, and quaternary. Okay, so 4 levels. Primary care services are things that you're going to access on a fairly regular basis. Your primary care physician, your family doctor, your OB, if you need physical therapy, occupational therapy, imaging, lab, things of those natures, things that you're going to access on a fairly frequent basis, right? Those services in our rural communities, we should expect those to be fairly close to home, right? Well, you shouldn't have to drive an hour or 2 hours or whatever to go see a primary care physician, right? I would hope that those are typically within 15 to 20 minutes of where we live, right? Yeah, if you can, right? That's a pretty reasonable thing to think about, depending on where you live. If you live out in, let's say, it's Seligman, for example, right? There's not enough patients in Seligman to have an actual person be there, right? So we try, as you get further and further remote, that's why I think telehealth and telemedicine is really important from an infrastructure and investment perspective. And hopefully Stephen will weigh in a little bit on that as well. And then when you think about the next level of care is more secondary in nature. So those are more hospital-based services, so inpatient beds, surgeries, so orthopedics, GI, things that you're going to hopefully use on a less frequent basis. So for example, I hope that you're not coming to see an orthopedic surgeon for a broken arm once a month, right? that would be something that maybe you're gonna go a little bit further for, maybe you're 30 minutes to an hour for a secondary level service. Then tertiary level services, some rural communities don't have any tertiary level of services. So when I was living in Grinnell, the closest tertiary centers were either Iowa City, 65 minutes away, Des Moines, 65 minutes away, right? If you live in Pella or some other place. And the reason I give that context is we are very fortunate that we're living in Sedona, the Verde Valley. We have tertiary services close by, and that happens to be the Flagstaff Medical Center. Tertiary services are more complex in nature. So neurosurgery, complex vascular surgery, complex orthopedic surgery, complex trauma services, heaven forbid that you fall off of a cliff hiking or you get in a car accident. Those services are going to be a little bit further away, but much larger infrastructure. And then quaternary care, and there's probably only a couple of those in the state. There's Banner University Tucson, Banner University Phoenix, Mayo, and St. Joe's. There's 4 of those in the state. And what quaternary level of care services are more like heart transplant, lung transplant, liver transplant. It would be oncology, trial studies, experimental stuff that's going on. I always tell everyone, and I say this, I've heard it before, if you happen to lose a digit, heaven forbid, you're not going to want to come to Northern Arizona Healthcare. There's like 3 surgeons in the state that do micro revascularization of fingers. And so my recommendation would be we need to go to Phoenix or Las Vegas or someplace like that. And so I give all of that context because I think it's important for us to understand when we talk about maintaining and expanding healthcare in our regions, what are we talking about? What we're talking about in the Verde Valley is we're talking about maintaining and expanding our primary services. So primary care, lots of primary care, pediatrics, OBGYN, physical therapy, occupational therapy, imaging, lab. We need to continue to invest in that and expand those services because, as someone mentioned, the healthcare system, whether you're at Northern Arizona Healthcare or anywhere, is extremely hard to use. And we have to work on that as an industry to move that forward. And the best way to stay out of our hospitals and not climbing on the roof and all of that stuff is to go see your primary care physician, right? And if you can't get into your primary care physician, then that's a risk, right? And we haven't done a good job of that in the last 2 years. And then we can talk about why that is and where we're at today. So what do we talk about when we think about the Verde Valley? What do we even mean? And I just go through that. I'm sure you guys all know what that is. This is how we're kind of situated. So here in Sedona, we have an emergency department. We have some primary care. And I'll talk about what I think our vision is for Sedona specifically moving forward, because I think we have not been 100% clear of what are we going to do in Sedona and why. And I think what you're going to hear from me, whether you like it or not, I'm a Midwest kid. I'm going to tell you what I think, and whether people like what it is, but you're at least going to get an honest answer of how I think we think through it. Then we have Verde Valley, which has the secondary services, so surgery, surgery ORs, inpatient rooms, medical office buildings, et cetera. And then Camp Verde, which is more of a primary service offering. So here are all the services we offer. Certainly this presentation is available to each and every one of you, how we think about our regional service offerings and how we get to those various areas. And then I think that the thing that's important is, and this kind of will lead into the overall investment of capital and infrastructure in the region. Last year alone, we invested about $12 million in infrastructure into our Verde region, and that really goes to more boilers, chillers, parking lots, equipment, et cetera. And the reason I put that up there because there's a lot of discussion, and I should have led with, I was with the Mingus Mountain Republicans on Tuesday. I'll tell you right now, you guys are already way more fun. You guys are up, and so well done on that. A little lighter crowd, which I appreciate. Because I think what is helpful for me being in this seat and with each and every one of you, we're all here to try to do the same thing, right? We all live in these communities. We want excellent healthcare. We want economic development and growth. We want to be able to live in our communities for a really long time. And what I was hearing when I was first going out was, well, you're investing $850 million in Flagstaff, and you're taking all the money out of the Verde Valley. How many people have heard that? That could not be further from the truth. The $850 million investment is in tertiary level care. And what we need to make a decision as a community and a hospital is, do we want tertiary level care in our region? If we don't need tertiary level of care in our region, or we don't care if we have it in our region, we don't need to make $850 million investment. We believe as an organization that, heaven forbid, I get in an accident going back up 89A, I want to be able to have that level of care where I can have my life saved and not have to go to Phoenix or Las Vegas or wherever it ends up being. And so we believe that investment is important for the region. In conjunction with that, that investment was made or is being made under the pretense that we have to continue to invest in the communities that we service today and be able to expand in those communities, again, from a primary and secondary service perspective. So I put that up, and that's just the physical infrastructure. That was also intended when I started talking about this in August of last year, which, geez, it's been almost 6 or 7 months now. There were a lot of rumors that we were closing the Verde Valley Medical Center. We were going to put this hospital in Flagstaff. We're going to close down the Verde Valley Medical Center, and then everything's going to go to Flag, right? And so this is a little bit saying no organization invests $12 million in infrastructure you can't even see if your plan is to close it down, right? You don't put in a new air handling unit, you don't put in boilers and chillers, you don't fix the parking lot, all of these types of things. And then, so that's on the capital side. Then we also invest in service, right? So not every service that we tend to do generates excess revenue over expense, right? And we talked about excess revenue over expense goes back to reinvestment, but we are continuing to invest and expand in primary and secondary services. So primary care, I'll go through them again because I think that's really important. Primary care, primary care, primary care, you're gonna hear that from me a lot. And then our secondary level services like general cardiology, interventional cardiology, GI, orthopedics, neurology, potentially rheumatology, ENT. Those are all areas that we're thinking about expanding, either maintaining or expanding from a secondary service perspective. Let's see if we can get it going.
Just to be clear,
Yes.
the Verde Valley Medical Center is a secondary care facility.
Yep. So yes, thank you so much. So Flagstaff Medical Center is a tertiary level center. Okay. Verde Valley Medical Center is a secondary level center. And then the rest of everything, even in Flagstaff, there are primary services. Like so in Flagstaff, we have primary care, we have all of these things. Same thing in Camp Verde, it's a primary service. Cottonwood has primary service. Sedona has kind of a mix, to be honest. They're kind of primary and secondary. An ED would be considered a secondary service. By the way, we have no intention or plans of closing the Sedona ED. That is not happening. Okay, so I'm here to say that. And Bill Johnson, I hope I got that wording right. So Bill's listening. He tells me sometimes I get the wording wrong on that, but we have no intention or plans of closing that facility. But I will talk a little bit, if we have time, what I think that facility should change into. Okay, how many of you heard we're putting a cancer center here, comprehensive cancer center in Sedona?
Went away.
That doesn't make any sense.
Nope.
It doesn't. I mean, so I'll tell you, and if you want, we talk about why. What I think the Sedona Medical Campus could, should, and will be is a primary service hub that has primary care, internal medicine, potentially OB, rotating specialties that come through, cardiovascular services, orthopedic services, et cetera, physical therapy, occupational therapy, lab, imaging, ED, urgent care. That should be the center, right? We go there for our primary and a little bit of secondary service needs. If I have a heart attack, or I have a broken bone, or I'm having some kind of internal bleeding, you're not going to get taken care of at SMC. You're either going to go to Cottonwood or you're going to go to Flag. And so I just want to be really clear on that, because I know we've spent a lot of time, and I think right, wrong, or indifferent, I think we did that as a trade. You know, we're going to shut down the ED, we'll put a cancer center here. That's ridiculous, right? And so I'm here to tell you what we're putting in Sedona will be exactly what the community needs and what is going to be accessed regularly on the community side. And we can talk a little bit about, and what we're kind of starting to show here is, here's what all we've done, at least in summer, and I think this is actually even a little outdated. I think there's some more people coming here. So in Sedona, there are now 2 internal medicine physicians in Sedona, Dr. Locke, Dr. Lloyd. We just offered a third, this will be a practitioner who's a female who'll be joining Sedona. So we'll now have 3 primary care providers in Sedona. We're back ahead of where we were kind of pre-pandemic. Don't take that as that we're stopped, we're done, we're good to where we were before. We will continue to invest in those services. Village of Oak Creek is now full. And as you can see, the reason we put primary and specialists on there is because I would talk a lot about the primary side, and then people would say, well, that's because you're not investing at all in specialty. We're doing them both in conjunction, but we're heavily focused on the services that you're going to use on a very regular basis. And then we're adding stuff like orthopedic surgery, EP. So just so you guys can go out and talk, electrophysiology is a service that we've never had in the Verde Valley. So you either had to go to Flag or you had to go to Phoenix to have it done. The EP physician that actually works in Flag actually lives in Sedona. We actually are hiring 2 more electrophysiologists. We're building an EP lab in Cottonwood. So for those of you who are not healthcare professionals, EP is essentially the rhythm of your heart, and they shock you to get you back on rhythm and all of that good stuff, pacemakers and stuff of that nature. And atrial fib is AFib is a really common thing that they do. So we'll now have a center in the Verde Valley that will be able to do those types of procedures, and Flagstaff. In addition to, if you want to go to Phoenix, you certainly can. And then I'll just quickly go through and I'll buzz through these pretty fast. Do you guys want to talk about the board and how we make decisions, or do you want to talk about the new the $850 million investment, or do you want just questions?
Question.
All right, here we go. All right, well, 2 questions. I think that's the net of it.
Oh, you want me? Okay.
Yeah, go ahead.
Okay. So 300. So I'll launch it with kind of a personal anecdote that's happened recently that I think speaks to some of the concerns, and I don't mean to speak for everybody, about the number of providers.
Yep.
So a very close friend of mine recently had some head trauma and was experiencing some other issues regarding to the brain. Had an MRI, which that wasn't that hard to get.
Yeah.
But an appointment with a neurologist was postponed numerous times at the Verde Valley Center. Finally happened weeks and weeks after, which could have been potentially dangerous if there was a serious issue. And I understand that the neurologist who was there had either left. I don't know why there was an absence, but they finally was a new person added who apparently was from the Mayo Clinic, an Asian doctor. So what's the deal with a department like neurology as a secondary service in Verde Valley, and how does it? And what about just the doctor population in general?
Yeah, so I think a couple different things. Well, I want to answer neurology first, and then I think we should talk about what we've kind of experienced over the last 18 to 24 months and where I think we're going, because I think that's important context. And someone said, well, it can't be all bad actors. You're right, they're not all bad actors, but I can tell you, I'll tell you different examples if you've heard this before, of individuals that we've parted ways from a medical group. So from a neurology perspective, it's probably been about a year and a half ago, I was able to recruit, his name is Dr. Jeremy Payne. He's a stroke neurologist. He started the first comprehensive stroke center in the state of Arizona at Banner University Medicine with me. So he will be coming, or he's here. He's working on building a comprehensive stroke center for the region. So when we think about that, a comprehensive stroke center is something that is a tertiary level of care. That doesn't mean that we don't need stroke and neurology capabilities across the system. To your point, we need to build neurology and stroke capabilities at Verde Valley Medical Center in our secondary area and build out our neurologist population. Neurology is really hard to recruit. And so there's some of those areas too, where you think about, it's not lack of desire or effort. I'll give you one example. We used to have occupational medicine in the Verde Valley, and that was probably about 2 or 3 years ago, that individual moved to do a concierge practice. We've been recruiting for an occupational medicine physician for almost 3 years now. And we've also tried to recruit them to Flagstaff, thinking if we can get them to Flagstaff, we can rotate back and forth and we can at least get some coverage. We can't even find an occupational medicine provider. That being said, certain specialties are harder than others. We've done really well in hospitalists, anesthesia. We've done really well in recruiting primary care. Orthopedics has not been a challenge. Interventional cardiology has been. General cardiology has not. So when you think about those areas, there's certain macroeconomics that are challenging from certain specialties, and then we have our own regional challenges as well. Some people will say to me, "Well, it's housing." Yeah, that's one component. Actually, the most common thing that we hear, at least from physicians, is trailing spouse jobs. So they can come get a job, but if they're not in the healthcare field, or they're in IT, or they're in something else, we don't have any other job for them. And so I talk a lot, obviously, some of the city things like economic development, because the more we can grow that population, the better. And just quickly before we go to the next question is, so what we made a decision about 18 or 24 months, that's probably closer to 24 months ago now, was that we were going to have the same expectation from a quality perspective for the care that we delivered and a service perspective from the care that we delivered from all of our providers across our system. So if you went to Flagstaff or you went to Phoenix, you should have the same quality of care that you receive and the same service. And we had some turnover from that. And I always give the one example. I'll give a different example of a provider. I'll give you two. I think I know which ones I use there, so I'll use two different ones. Yeah. So one, we had a physician, and if I use this example,
It's
I-
okay. I might be the only person who heard it.
we had a physician that their common practice would be to come in to the hospital every day. And the first thing that they would do is they would look through all of the people that had been seen in the emergency department in the previous 24 hours and see if they knew any of the names, and then look and see why they're in the hospital. Who does anyone feel good about that? No. Yeah, right. So that's one that I don't think I talked about. We had one.
Can I have a question
Yeah,
about that?
yeah.
Why? Why was he, what was his
His or
purpose
her?
of doing?
Is her.
Is there? I would say curiosity. I think it was curiosity, because it would be what would happen. The only reason it actually got caught was this individual saw a patient's name they knew, looked in the chart, called the patient's friend or neighbor and said, "Did you realize so and so is in the hospital? Would you go?" So
Part of the reason I ask,
yes.
occasionally our own primary, this is in my life, our own primary care patients were admitted to the hospital and we never found out about it.
Yep, this is us.
And that's a communication issue between the hospital and the. primary
This is
care
a specialist who would come to the hospital every single day. So no reason, just for Cardi, no reason to be looking through the chart to find stuff. That's a very different scenario.
Got it.
Second example, and I think these are both different than the ones I gave before, so I will have now given at least 4 different examples in the community about this. We had a physician in one of our primary care clinics that did in front of a patient, picked up their stool, threw it against the wall, and said, "I can't fucking deal with you. I can't effing deal with you."
Stretched out.
So, and had it been a one-time thing, there was other instances that go on. We had another physician, I'll give a third one, so you have 5 total that I've done in the community. And if you think about it, I just said we replaced 11, right? We lost 8. So I just told you 5 of the 8, right? So, you know, we had one physician who, and you've heard this one before, who said, "I wish all of those unvaccinated MRFers would just die."
Nice.
No longer with our organization. So I can keep going through a lot of those, and to someone's point, some of them are egregious that are one-time things, like you just don't act that way. I will tell you, we have been extremely generous in probably 99% of those where there's a pattern of behavior, a pattern of we can't act that way, we can't operate that way. So hopefully I answered your question on some of the providers.
Yeah. Before I get here, online, Steven Zuckerman, if you're there, do you have a question?
Yeah, so I'll ask you a quick question. So when you talk about like bringing physicians into the area, I mean, obviously there's an issue of will there be enough patients for some specialties? But question that I have is, what kind of problem do you have with sort of lack of colleagues? You know, if you bring one specialist in who doesn't really have other colleagues in his or her specialty, is that a recruitment problem for you?
Absolutely it is, and you hit on a good thing. And I want to correct something. Our expenses are variable. Our expenses are all over the, you know, we can to your point, we can drill down on productivity, and you start to make some of these decisions that he's talking about is what services can you afford to do right in today. But it's a huge problem, and I think that's why you've seen some turnover. Like how many people, hopefully you don't have to tell me this, but has anyone heard of people having multiple oncology providers? Right?
Hematology.
Yeah, cancer. How many people have lots of different cancer doctors? Right? To Stephen's point, in certain of our areas, we're not big enough to have enough patients to create a full program around it, right? Or a team, right? So you're on an island a little bit. And so what we've tried to do as a system, at least in the last 3.5 years that I've been here, and I can give you some examples of it, is we've tried to say, when we're recruiting, and how do we bring the services together? How do we say cardiovascular program is Flagstaff and Verde Valley, and we rotate through, so we have other colleagues and systems in place. But to Stephen's point, yes, it's a real challenge for an area like Neurology is a perfect example in the Verde Valley. We probably have enough neurology business in the Verde Valley for a half of a neurologist, not a full-time one, but probably a half of a neurologist to keep busy, right? So what we historically would do is we would have one neurologist, right? They'd be half busy, but we would never flex them back and forth. And so what ends up happening is, what happens when that neurologist goes on vacation? What happens? We don't have the service. Well, that's not a good model either. And to your point, Stephen, yes, it's a tremendous challenge because some of the providers that are coming to the region, especially, I'd be curious at his perspective on this, the newer trained, they're becoming so specialized that 15 years ago, it would have been the interventionalist might do the general cardiology and everything. Now, the interventionalists coming out now, they want to be in the cath lab doing interventions. They're not going to manage the medication and all that stuff. And rightfully so, on some aspects, that's how you get really good at it, right? It's like shooting a free throw. I shoot 2,000 free throws a day. I'm going to get pretty good at it at some point. If I'm only shooting one every three days, I'm probably not. So great question.
Okay, so we're gonna go back and forth to the live and the at-home, because we want to make sure the at-home people get their say. So let's go right here.
I have two questions for you. I'll make them really quick. The first one is, as an interim CEO, are you hobbled in making long-term decisions to affect the future of healthcare in the system? That's number one question. And number two is, there's 30 acres sitting around surrounding the medical center. And if housing is a major problem, especially for support members of the healthcare team, do you have any plans on creating housing, creating assisted living? How do you plan on using that land?
Yeah. So I think to answer your first question, a brief answer is yes and no. Hey, I'm in politics, right? Yeah. I would say know that we can make the decisions of what we're going to do. Yes, and if I'm not selected as the permanent person, that could change in 6 months, right? So I don't feel that we can't make. So what I'm telling up here, if I'm the acting person, that's what we're going to do. Primary services, not the acting, the permanent person. That's what we're going to do. That strategy isn't going to change. I can't confidently stand in front of you today and say, well, if they put someone else up here, they don't think like, wow, well, we should do this and that there. I don't think our strategy is drastically off, that it's going to change from a huge swath, but I don't know the future of that. So I don't know if that answers your question, or you feel better or worse about that. I don't know. As long as I'm sitting at the helm, what I just told you is what we would do and what we will continue to do. As it relates to the 30 acres, I don't think we'll do housing, but I think we will look at finding a partner for assisted living.
Okay.
So if any of you have heard about Valley View Care, and I could talk a long time about that, and we're not to disparage prior, 15, 20 years ago, we made a lot of decisions that didn't make a lot of sense, right? And we have a better team in place now where we look more forward thinking, what can be sustained, what does the community need, how do we continue to do that? And Valley View Care was a perfect example of that. It was a great idea. It was supposed to be a hospice home in the Verde Valley, except we never licensed it as a hospice home. It was 10 beds, those aren't really efficient. It was getting used about 40% capacity. It was costing about $1.5 million a year to run it. All of that to be said, it was a great in concept, but we didn't know, I'm gonna say NIH didn't know, we didn't know what we were doing, right? So what we're doing now is we shut that down and we're out looking for a partner who can make that into a probably / hospice assisted living, lease the land, actually create a senior living space near the hospital. We won't run it. We're not good at that. I'll just tell you that right now. That's not in our core competency, but that's what we're looking at. And we would look, when talking with Steve, I think that'd be a better use for the 30 acres around the hospital than residential. So we'll look at that. Yeah.
All right. Can I just piggyback on that? On the interim, what's the timeline? When is this decision being made? How long are you going to be in that hot seat?
Yeah. Well, any support you guys want to give, I will never turn that away. But I would say I think probably by May or June, they'll have so another 4 or 5 months, and you'll kind of know what you're gonna do.
Okay, let's get it online.
This is from Babe and Hannah in the chat, and they're asking, will specialists in fields such as cardiologists, pulmonologists, urologists, and oncologists from Flagstaff have office hours in the Verde Valley for patients in this area?
Yeah, that's a good question. And I think it depends on the specialty. You listed a lot of specialties there. Cardiology, I think we have enough cardiac work that we're trying to build a more comprehensive cardiology program. We are still encouraging all of our staff, if they want, to rotate back and forth. Perfect example of that is anesthesia. We employed anesthesia about 2 years ago, and we've done a lot of rotating down from flag staff here. But as we're about back to full tilt on our anesthesiologists, there's a couple of anesthesiologists that want to go to flag, right? Because you just see different patients, right? And flag, you're seeing level 1 trauma, you're doing more complex cardiac stuff, and that's good for people's skills. So I think we'll see more of that. So short answer is yes, depends on the specialty. We haven't had a pulmonary clinic here, at least since for quite a while here. We are working on employing our critical care physicians and pulmonologists. And from there, our anticipation would be that we will open up a pulmonary clinic in the Verde Valley. I don't have a time frame on that yet. We just a couple weeks ago decided we're doing that. So.
Okay, anybody? Diana?
On that note, I've got two as
Yeah,
well.
sure.
I heard that you cut the contract for pulmonologists up in Flag. So that's one.
Yep.
And the second one I heard you say is that the BOC is full for just regular care, but I can't get an appointment for 2.5 months for something that's fairly urgent.
Yep. So I think so. Let me answer the second one first. So we have a third provider coming there. They're not there yet, but I would say, and I think it's true of all of our clinics, they have same day access, or you can call. It's called Doc of the Day. So Dr. Rooney's there. So if you call in the morning at 8 and you say I need to be seen today, they have slots that are open for that. And if not,
I've been told to go to the emergency room.
okay. Well, if you want to,
if I can't get an appointment, if I can't wait.
Yeah, if you want to give me your information, I know in all of our primary care clinics, at least in the last 3 or 4 months, we have Doc of the Day. And so you have to call at 8 in the morning, but they reserve slots throughout the day to see ill patients. Now, I don't know, we don't need to talk about what your specific thing is, but on the critical care thing, I think really important clarification is we said we were not going to renew our critical care contract with our intensive care group within our hospitals. And there's 4 reasons that NIH employs providers. One, our support payment that we provide to those independent providers. So when they say they're independent, just so everyone knows, most independent providers NIH provides some financial support to for them to be able to continue to provide service in the community. If our financial support payment is near, equal, or greater than it would cost to employ a group, then we decide to employ. Okay, that's one reason. Second reason is hard to recruit or low volume areas, i.e. neurology, right? So we think we're in a better position to be able to support that economically. The third is if we're at risk of losing a service. And a good example of that is if you guys have been here long enough, we were employed cardiology, we were independent cardiology, we're back to employed cardiology. And that was when Mountain Heart, it was shortly after I got here, the providers that we have now came to us and said, I can't make enough money in private practice. I don't like the way the practice is being ran. If you don't employ us, we're leaving in the community. So that's an example. That's why we did Mountain Heart, and that's why we had to do so fast. The fourth one, which is a little more gray, is more around the ability to create an integrated delivery system and having appropriate physician leadership and commitment to what we need to accomplish as an organization, and whether or not they will integrate with the health system and do it. And that was an instance in Critical Care Associates. The real clear thing about Critical Care Associates, we did not renew the agreement for our ICUs. We did not have anything to do with their pulmonary clinic. They can continue to operate a pulmonary clinic all that they want. They can stay in the communities and operate a pulmonary clinic. They don't have to be employed. That is strictly a decision by that group to either maintain their pulmonary clinic or not. What we're saying is we're going to start our own critical care group. They're going to staff our ICUs, and we're going to open up 2 pulmonary clinics. We're going to open up one in Flagstaff. We're going to open up one in Verde Valley. Hopefully that answered your question.
Yeah, we have one from the chat from Kathy. Can you explain the renegotiations with Blue Cross Blue Shield? Because conflicting letters have been going out from Blue Cross Blue Shield.
Yeah, so we're actually not in that issue. That's a Yavapai or YRMC issue today. Now, that will happen, I presume, for us sometime in the summer. So we're watching that really closely. So what's happening, and I would love Stephen's perspective on this too. What's happening is everyone knows that we had 9.2% inflation last year, right? And so as an organization, our contract labor is up about 1,200% yearly. We spend $5 million in contract labor. This year, we'll probably spend about 60 million in contract labor. Now, I would love Stephen's perspective on this too. I think one of the great things about CARES Act is when we were going through this pandemic, hospitals weren't able to do elective surgeries, and that's how we all currently make money. Whether that's right or wrong, we can talk about that as well. So the federal government gave all these hospitals tons and tons of money. Well, what did it do? It changed the dynamic of the free market expense side, and it didn't change any of the revenue side, right? So hospitals had more money to pay travel nurses to come provide the care. So at some points in our system, we had travel nurses making the equivalent of over $400,000 a year. You had a hospital that's working alongside of them, made $260,000.
Changing careers.
Yeah, right. So all
Regularly employed nurses were way below that.
correct. Yeah. And so what we also then did, right, wrong, or indifferent, and whether that's sustainable long term. I mean, I have these flashbacks of who remembers 06 to 08 when everything was amazing, and then all of a sudden everything pulls back. We made about a $13 million investment just in our nursing staff as well. And so every single year, here's a fun fact for you. If you give them, who thinks a 3% raise every single year is enough? Okay. Nobody. It's just for everyone online. No one raised their hand. What do you think a 3% raise represents on NIH's salary per year? About $12 million. How much money do you think NIH made last year?
That's the math.
$7.5 million. So that's where we're talking about. And so what, to answer your long answer to your Yavapai question is, to Stephen's point, he's right. The insurance companies are paying for most of that because Medicare and Medicaid don't cover the cost of what it costs to actually provide the service. And you can argue about, is it administrative? Is it, we haven't even talked about pharmaceuticals, implants, device companies. They make a lot, so it's really a lot.
Stephen, you want to add anything to that?
I guess the one thing I will say is that there's no question, and this is probably something you're not going to probably like, but you might actually, as someone who buys services. I mean, I think healthcare markets, and they don't work particularly well the way other markets work, and I think that at some point, medical suppliers, pharmaceutical companies, there needs to be some oversight of pricing. I know, the R word, regulation, is a dirty word, but I mean, I think when you have markets that don't work, you probably do need some regulation, especially when you have these very, unique situations where a supplier can really exert monopoly power over a provider. It's not fair for the provider. It's not fair for you guys to be on the hook when there's a medical supplier that's really exerting pressure. So I mean, it's a very difficult situation to navigate. But I mean, I do think that, I think right now the adjustments under COVID, I mean, what you're saying, I can imagine it was crazy. I have no doubt that things were crazy during that. But I mean, I think that people really need to ask, is healthcare going to be run as a business, or is it going to be run more as as sort of a public service?
Yeah. Questions? Well, you had one before, right?
Yeah. No, I haven't had. Oh,
Yeah,
someone else. Yeah.
Ronnie?
Yeah, really large problem here in Sedona is primary care physicians. I've had 3 in the past year or so, and they keep leaving. The primary care physician I'm using now is in Cottonwood, and I was told that she was fired by Northern Arizona Healthcare because she didn't see enough patients per day. And she then went to
who was that? Patty Smith? Was it Smith?
No. And she went to another group in Cottonwood, and I heard about her from a friend of mine who had used her prior and then found out where she was because she wasn't allowed to contact her previous patients when she was fired. And I went to see her, and she said, I'm not an automaton, and if I need to spend more time with the patient, I will, which I really liked. And all of a sudden I hear now she's leaving. and I don't have a primary care physician anymore.
Yeah, okay.
And I don't, and there are a lot of doctors that I don't want to see.
Yep.
I'm interested in a woman.
Yep.
And I don't know where to go.
Yep, I think that's a great comment, and I have as long as you guys have, so just so you know, I'll take whatever time to answer any questions for you guys, so we don't feel like we're running.
Thank you.
I think there's a couple things in that. So I will say, and thank you. I don't know where you got the bio or who wrote that. It was way more generous than I really. Well, boy, did they indulge. But what I'd say is, this is the only place I've been in the country. So there are standard templates for primary care in areas. You'll know this. Most new patient visits, and this is a guideline. This isn't. You have to be in and out in 30 minutes otherwise. Most templates are built 30 minutes for new patients, 15 minutes for existing patients. That doesn't mean that if you need to take 45 minutes or 50 minutes, you can do that. It's just how you plan for a schedule, right? This is the first place I've been in the country that we allot 40 minutes for new patients and 20 minutes for existing. The gold standard across the country is 30 to 15. So I think there's always something underlying that's going on there. I think that's an easy excuse to say, I'm having to see too many patients. It is very, I say the expenses are variable. There's one expense that isn't necessarily variable, and that's physician compensation. That's very heavily regulated. And so what we have to look at, and again, if Stephen wants to tack on and say, yeah, you're wrong or you're right, or I have an adjustment that we're not allowed as an organization, as a hospital organization, to pay for more than what a provider produces, right? And what that does is called something called a work relative value unit. And we're held to that standard because we're a hospital, right? So in private practice, if you think they're out on their own, they're hanging their own shingle. For every patient that they see, they bill, they collect, they pay their staff, and they get whatever's left over. In an employee model, we pay you for being our physician, right? And the way it works is you go, there's lots of surveys out there, you go and you say, I'm gonna make up, there's a primary care physician, and you probably know this, we can pay you $100,000 at the 50th percentile, and we would expect you to do 50th percentile work, right? Which means average. You're not doing more, you're not doing less, right? But I want to be paid average, I'm gonna work average, right?
So is what average based on the number of patients you see? Because that's the
Yes.
variable, right?
No, yes,
Okay.
it converts to work relative value units, but they're assigned to patients, right? So if you make 100,000 at the median and you're supposed to see 1,000 units, which might be 1,000 patients, it might be 200 widgets. What we see oftentimes is, again, you can make more if you want. If you want to see 2,000 patients, we pay you above and beyond. What happens oftentimes in an employee model is you make 100,000 and you're seeing 500 of these things. We, regulatorily from the federal government, have to correct that gap underneath Stark. So what they think, and again, Stephen, interrupt anytime you want. The way the government views that is we're paying a physician to bring the work to us, right? And so we have more risk the greater that gap is. Does that make sense? So in theory, if this individual wanted to, we could say, you can see as many patients as you want, as little as you want, as many as you want. We'll just pay you for every patient you see. That's your choice. What we often find is, well, wait a second here. I want to make 100,000 and I'm only seeing enough to make 50, right? That's the gap or the delta. So hopefully that helps. Yeah.
Well, whatever the problem is, the big problem is that there aren't enough doctors, primary care physicians in the area.
Correct.
And we wind up going to a nurse practitioner or a physician's assistant.
Yep.
And if you have generally fairly
Yep.
good health, you're fine.
Yep.
If you're on the older side,
Yep.
you'd rather see an MD, where are they?
Yep. There's we've hired 11 primary care physicians back and we had lost 8, right? Or
And
providers.
so why are you losing physicians?
Well, we talked about 5 of them, right?
Yeah.
Throwing things against the wall,
Okay.
the unvaccinated MRF, and all of this stuff, accessing charts that you shouldn't. There's a whole host of reasons. Now, that isn't all of them. I would say there's, I know one anesthesiologist left because we systemized the anesthesia. So we had one physician leader that we put over it. There was a physician anesthesiology leader in the Verde. There was one in Flagstaff. We consolidated and said, well, we didn't consolidate. We said we're going to go under one leadership structure. So we had the same anesthesia protocols and stuff across the system. and we made one anesthesia provider the leader, and it happened to be the guy who got the job was in Flagstaff, and the other person decided they wanted to leave. So there's a whole host of things there.
Let's go to online.
Yeah, so we have a question from Babe. Do you have a committee to determine the needs of the Verde Valley? Like, is that something y'all are actively doing?
So one, I get feedback from here, but the way that most modern healthcare systems look at what the need is we get really good, it's called telemed data. So we know where specific patient zip codes are happening, where growth is happening, what services are getting done outside of the region. To your point, if it takes us 3 months, we look at that. Okay, we need more primary care providers, and there's a combination there, right? We just talked about if you have primary care providers that are operating at the 50th percentile, they're getting paid, and we still have the lag in patients. We need more providers. If you have primary care providers that are seeing 25% but getting paid at 50, the question is, do you need another provider, or do you need that provider to do more or less? As an example. So we use all of that data, then we look at transfer center data and growth data, and then any feedback from the community here. But like one that comes up quite frequently is rheumatology. Rheumatology is extremely hard to find to recruit, and I doubt you're going to find an independent provider that's going to come to the community to do that. It's probably one of those scenarios that Steve was talking about. We can probably support one rheumatologist. There's probably not enough rheumatology work for a bunch, but I don't know, but hopefully that answers your question.
I just have to, I'm going to jump in for a minute. I put something in chat. I do need to sign off. I have to go to another meeting, but yeah, I think the issue of primary care and payment. I mean, I think that's a serious problem with the fee schedule. I think that primary care fees probably are not high enough to support the work they do. One comment I would just make is that in a lot of areas, it's not a rural healthcare issue. It's not a small city issue. In a lot of areas, physician practices are employing nurse practitioners and physician assistants to kind of extend the work of the physician. And you know, that's just the way primary care is evolving at this point.
Yeah, that's a good point.
Thank you. Stephen, thank you.
Thank you very much.
Yeah, we appreciate it. Let's hear it for Stephen.
Take care.
Now the rides question. Okay.
All right, I'll come to you in a minute. Linda?
A little specific question. I noticed in all your listings, you didn't talk anything about cancer care. Do you not see yourselves as a cancer care provider or not?
No, we do, and I thought it was on one of those slides. I may have buzzed through it. It's so yes, I think that what we view is that we'll have a cancer center in the Verde Valley and we'll have a cancer center in Flagstaff.
When? 2 weeks to Flagstaff for immunotherapy. And I'm thinking immunotherapy, it's like a 15-minute delivery.
Is it just infusion?
Yeah,
Why are you not able to do it in Cottonwood? We have infusion therapy there.
I don't know.
Oh, or reach out to me afterwards. So I think so today we have a cancer center in both locations, right? We just started our own cancer center in Flagstaff about maybe a year ago, right?
The one with Mather.
No, Mathern's an independent provider.
Oh, okay.
So that's probably why you're driving to Flagstaff. But so that's where it gets a little bit complicated. So again, this is where you think over the last, I've been here about 3.5 years, trying to systemize services and make sure that we're doing things the same in both locations, right? So previous to Mathern, we were an independent, or we had our own cancer center in the Verde Valley, and Mathern had an independent practice in Flagstaff. So like radiation oncology, we use an independent group across our system for radiation oncology. We're going to all of our own medical oncologists, and then we've seen a lot of turnover in those areas. We've historically built programs around physicians rather than building programs and finding the people to do it. So you see a lot of, I'll give you an example. I want a breast imaging center and a comprehensive cancer center right here in Sedona because people are going to travel from all over the world to see us. Sorry, I mean, that's no offense to anyone in here or me. That's not going to happen. The only way that's going to happen is if we go to MD Anderson or we go to City of Hope or Mayo and we say, put your name on it. They'll come here for part of it. But to your point, they're not going to come here and travel for a 15-minute infusion 3 times a week. That's not going to happen, right? So in my opinion, and again, we can debate that. So what we envision is a comprehensive cancer center in Cottonwood, a comprehensive cancer center in Flagstaff, and those will be services all wrapped together. So if you think about the current cancer in the Verde Valley today, which is crazy, and then when I talk about not thinking through what we're doing, right? We have breast in Sedona. We don't have any imaging here, but we said we were going to put imaging here, but that's really not a great. Yeah, no, not a great idea either. The medical oncology component of cancer is in Cottonwood. The infusion component of cancer is in Cottonwood. The radiation component is in Sedona. Think about that.
It got
Right.
moved.
Right. So what I view, and I've been talking pretty openly with this in the public, is I don't think we will have radiation oncology in Sedona. I don't think it's the right spot for it. What I described earlier about Sedona, I think that's what we need in Sedona. I think we need urgent care, primary care, physical therapy, occupational medicine, ED, all of those things as a service offering. And then I think where you see better care, and hopefully you'll agree with this, is when all of our providers, and that's what Steve was talking about, can be together as a care team, saying, I've got the medical, I've got the infusion, I've got the radiation, I've got all of that there. So we have cancer today in the Verde Valley. I would say it's probably going to take us, I'm going to say a couple years to get it all consolidated into an area. So we have it now. We have radiation, we have medical, we're doing surgical, but you're going to different areas. When you think about consolidating it, is then we're talking about a pretty massive building capital campaign. So we will have to put capital and we'll have to build a new building, probably adjacent to the MOB that is a cancer center in the Verde Valley. Same thing in Flagstaff. We have a cancer center there today, and it has at least that one that has med-onc, infusion, and rad all in the same building. But when we move to the new campus, there'll be a cancer center there as well.
Okay. Somebody in the chat?
So that you mentioned that interventional cardiology was not doing so good in the Verde Valley. For months, there was no interventional cardiologist. Is there one now? And why was Stephen Hildreth asked to leave?
Yep. So it was actually 2 weeks that we didn't have an interventional cardiology in the Verde Valley. We do have an interventional cardiologist today. They're
One or just
one? Just one.
Yes.
Temporary person, right? So we're recruiting for new interventional cardiology. I don't think I said that interventional wasn't doing well in the Verde Valley. I was saying
I think it was recruitment was difficult.
Yeah, recruitment's difficult. We had an individual that's supposed to come in February, Dr. Pack. He's an interventional cardiologist. His wife is an infectious disease physician at Mayo, and he ended up finding a job in Phoenix, so he didn't want to come to the Verde Valley. So we're back to the drawing board a little bit on interventional, but I would expect we probably will have 2 interventional cardiologists in the Verde Valley, general cardiology, and specifically with so I'll just be really transparent. A different one, and again, I say all this, and just so you guys know, that puts a lot of risk on me, and it puts a lot of risk on the organization. Right? I'm pretty open here. People can go, well, that's defamation and all that stuff. So if you sit from my seat and you have a physician leader, so our physician leader over cardiovascular services is Dr. Mark Passett. Dr. Mark Passett is with Phoenix Cardiac Surgeons, and he does heart transplants and complex cardiothoracic work at Banner University of Medicine. But he also comes up here and they do all of our open heart work in Flagstaff. Dr. Ken Fang, Dr. Orazio Amabile. You have probably some of the best cardiothoracic surgeons in the entire state doing work at Flagstaff Medical Center. Same thing with vascular. So they come and they say, we have some quality concerns and we have some behavior concerns for a particular individual. I'm not going to say who that individual is. You guys can try and kind of draw those conclusions. And I say, okay. And I say, what are the behavior concerns? Well, the staff are afraid to call a particular physician when they have concerns about a patient because they get yelled at on the phone, and so that's one scenario. Okay, have we talked with this provider about that? Yes, we talked about it multiple times. It continues to progress. There's not good chart, all of these things, right? And I say, okay, well, what do you want to do? We think it's best that this particular provider is no longer with the organization. I said, okay, how long before we can get a locums to cover, right? 2 weeks. I said, okay, so can we go 2 weeks so we don't have any gap in coverage? Is that because we did that at SMC for primary care. We knew we were going to have to get rid of someone before we kind of lagged it along, so there wasn't a gap in care. I said, go think about that. They come back and they say, we are so confident that we need a change from a quality and a behavior perspective. It would be better for the patients in the Verde Valley to not have interventional cardiology for 2 weeks.
Did you have this one?
That speaks directly to the quality of care that was being.
Correct. And so step two is Dr. Mark Tassett, who's probably one of the top cardiothoracic surgeons in the state of Arizona, is saying, I would rather the residents of the Verde Valley go to the ED, get temporarily taken care of and get flown to our center than to have what's going on today. So, I mean, and that's not my decision. So my decision is that's your decision as a physician and how you're going to handle that. And I trust that those physicians that are overseeing, and that wasn't just him, it was him and also the person who oversees all of our cath labs, Dr. David Leader. They collaborated on it and said, this is what we need to do.
Okay, next. Go ahead.
Okay, thank you for being here. I have a question. Are you aware, and if you are, how do you feel about the fact that many residents in the Verde Valley now consider Flagstaff as the closest available emergency department? And I can give you examples if you want. And I'm also aware of two women that have had babies at home recently because they feel like it was a better option than going to the hospital here.
Yeah, so about a year and a half or 2 years ago, so it used to be Flagstaff Emergency Physicians and Flagstaff. We were employed in Verde Valley and we were employed in Sedona. And about a year and a half or 2 years ago, we made the choice with Flag Emergency Physicians that they provide emergency care, at least physician-wise, at both of our some centers. So hopefully.
And that's the Verde Valley Medical Center, and Flag, not Sedona.
Correct. Sedona, we still employ the physicians there. Flagstaff Emergency Physicians did not want to provide the service in Sedona.
So do we not have
They do.
care, I mean, or
You have any
certain periods of time? Or?
No, we have 24/7 emergency departments in Verde Valley or Cottonwood, at Sedona and then at Flagstaff. So there are 3 of those. What I will say is a real challenge, not only for us, but across the country, is the overcrowding of our emergency departments and the amount of people that are accessing care there. Some of that predicated on we need better primary care services. Some of that being on we don't have a real urgent care platform across our region. That's something that we need to invest in. Certainly when I say that, people go, oh my gosh, they're gonna put urgent care in and remove the ED. No, it's just, we need those different levels of care because there are a lot of things that get done in our emergency departments that could be done in urgent care. That includes Flagstaff. That's not just here. And so we need to get to that.
But well, I guess you're not really addressing the period of time it takes. Like if you go to the emergency room with, and I can give you examples of a broken back, a heart attack, an appendicitis, and have to wait more than 12 hours to be seen.
Yeah.
Yeah, and I've driven somebody with a busted eardrum to Flagstaff because she couldn't wait. It just doesn't feel like there's emergency care available.
We have the same problem in Flagstaff, to be honest. I would say our probably fastest ED to get into is Sedona.
Yeah.
And that's why you're seeing more people coming to Sedona out of the Verde Valley, because again, it's a staffing and crowding problem, right? So we don't have the amount of staff that we need. And we're about eight nurses short in Verde Valley. But we have long wait times in both. It depends on the time of day, but long wait times in both our IDs. And I think someone mentioned something about cath lab, maybe that was it earlier. This is, and I wish Stephen was on to, because it helped. Actually, Stephen really helps me, right? Because it builds credibility, or what I'm saying is not just my opinion. But when I was at Banner University of Medicine, so it is the largest hospital in the state of Arizona. It is the quaternary backstop for anything that can't be handled anywhere else in the state, and quite frankly, sometimes from other states. For a period of 3 months, they didn't even have a cath lab. They couldn't take care of a heart attack because they didn't have the staff to do it. And that's why I talk about this massive disruption in labor. Now it's starting to come back down, but to your point, yeah, it's huge. It has huge impacts on our ability to deliver care. How many of you in here say, oh my gosh, well, they're shutting down, they shut down the lab draw station in Camp Verde, they shut down the lab draw station in VOC. Why are they're cutting services, right? The reality, and we're starting to get back to some of that normalization. The reality was we needed the phlebotomist in Camp Verde to go draw traumas and stuff like that because we didn't have enough staff to do it. And so we did not do a good job of is coming to the community and saying, guys, we're in trouble. And this is what we're doing about it. We're trying to keep all critical services open. So if you have something like that, the best of our ability, we can do it. And by the way, it's going to be a major inconvenience and problem in the short term where I can't go to VOC and get my lab drawn. I got to drive 30 minutes down to Cottonwood. That's the reason why. It had nothing to do with us saying, we don't want to provide the services we can't provide. We can't provide the services. So
Okay, it's almost 11:20. We're gonna go to 11:30 to cut it off, so, Holly?
hey, how are you?
I wanted to talk about breast imaging.
Yep.
So my understanding is that the last breast imaging specialist is leaving in June.
Yep.
And I don't know whether he was with Northern,
He's not. Yeah. I know where you're gonna go with that.
well, you have eliminated your contract with Northern Arizona. Okay. Why don't you tell us?
Okay. So this is where it becomes, and I stand up here and I don't mean to make it sound complex because it's an excuse, but I tell you, you can hear from some that like NIH is not supportive of independent practitioners, and if they would just be supportive of independent practitioners, everything would be great. Then you have, so NAR is an independent practitioner, right? We pay them money to be our radiologists and our breast imaging and all of that stuff. So they're independent, right? But then guess what? We have trouble with our independent practitioners. So to answer your question, yeah, I actually heard about that probably after you did, because they didn't call me until about 3 days ago. So you've probably known longer than I. But what I would say,
She's in the city council, so she
I know, I got to get the bat line straight to you. What are we going to do about it? I think it's a really complex question, and meaning.
What happened? You eliminated their.
No. So Dr. Ebersol no longer wanted to work with NAR. Dr. Ebersol has sent us a text and said, I've done everything in my power to continue to want to work with NAR. I'm moving to Colorado. I'm out. I'll stay through the end of June. So you want to talk about position turnover? We talk a lot about what NIH does and doesn't do about it. It's a problem. It's a problem across the region, whether you're independent employed. What I would say is we're building a better medical group that will have better long-term sustainability from that. And I think that could be evidenced by a couple of the areas that we're growing. I think our real question as an organization is I think there'll be something temporary put in place, meaning we have committed that we will have a fellowship trained breast radiologist reading all of our mammographies. What gets more confusing about that is we only do breast mammography in the Verde Valley. All breast mammography in Flagstaff is done by NAR. NIH doesn't do it. We don't touch it. They can do whatever they want. That's their business. So what we made the commitment is all of the mammographies that are done on our equipment in the Verde Valley will be read that way. So there'll be someone who's reading it, et cetera. I think the longer term discussion is for NIH and whoever becomes the permanent CEO is who is our radiology partner? Is it NAR? Is it a different radiology partner, or does it become employed? I think that's one section. What is also a little bit confusing in healthcare is NAR also provides interventional radiology, right? And as stuff is changing, things are becoming more specialized. So in the past, it'd be like, oh, I read breast, I read your broken bone, and then I go do my interventional procedure and I come back out. That doesn't happen anymore. That's kind of the model we kind of operate in. What we need to get to is who reads our radiology studies and who does our interventions. And so I think for NIH, we have to decide, I don't think we will ever employ interventional radiology. And here's why. I don't think we're big enough to employ interventional radiology, meaning I don't think we have enough volume to do it really well. So I think it will probably be, and if we do something different than what we're doing today, it would be in a similar model like we do with cardiothoracic surgery, right? So we're very blessed at NIH to have open heart surgery capabilities. I would tell you if we were just doing the program on our own and we didn't have the relationship we had, we wouldn't do it and we shouldn't do it. Because we do about 300 or 400 hearts a year at FMC. A cardiothoracic surgeon's probably doing, to keep their skills up, probably 150 to 200. And so if you're gonna cover 24/7, you need 5 people, right? You should be doing 1,000 hearts, right? So the reason that we're able to do that is because those individuals go down to Banner University and they do 400 hearts down there and they do 150 hearts up here. And so they keep their skills up. So we will maintain at least through the period that all of our mammographies will be read by a fellowship trained breast radiologist. We made that commitment to the community. We will not change that commitment. How that is done, I don't know today.
But you had till June to figure it out, right?
Well, there will for sure be a breast fellowship trained breast radiologist reading. They will find someone. I think the bigger question strategically for the organization is Are they the right partner? And if they're on here, I'll say, listen, are they the right partner? Because I think that's important. Are they the right partner? If they are, what are the standards that we want to have them meet? If they're not the right partner, who is our current partner? Or do we employ it? And I think those are the decisions we have to get.
Okay, another question?
Steve, did you have one?
Jessica.
Jessica does.
Go ahead, Jessica.
But I like your name.
I know.
Yeah.
And it's with the PH, which makes it.
Yeah, that would be a small
Okay.
thing.
Jessica, go ahead.
I just have a question about the Verde Valley Hospital down there. I noticed it's like 2 or 3 stories. Are the second, anything over the first story used?
Yes.
What's it used for? Because I don't see.
So you're talking about the tower. So first floor of that tower is imaging. Second floor,
I'm
geez.
talking about the hospital that I go into
Yeah.
for where I check in and everything.
Yeah, that's what I'm talking about. Yeah. First floor is, well, it depends where you're coming in at, I guess. I don't know where you're.
Yeah, I'm coming in at.
The
entrance.
only space that isn't used in that hospital today is, I think it's the 3rd floor, and that's a shell space for growth.
I have to say, it has, ever since I've been in Sedona, it has a terrible reputation.
Mhm.
People would say they would never go there for anything other than imaging, or
Yep.
maybe not even that.
Yep.
See, and there were people saying that you were planning on, because it's so crappy, that you were planning on bringing it back to a level 1. You remove the level 2. So could you talk a little about what are your plans for making that a more, and I guess this is what you've been talking about, or all your plans for making it a reputable medical facility instead of now it has an incredibly bad reputation.
Yeah, so I think it's a great question. And I think there's a couple things that we need to do and could do and should do. So I'm gonna ask you guys a couple questions. And if you've heard this before, you can't answer. Okay. Who is the #1 hospital in the state, risk adjusted, if you get admitted, to not have a urinary tract infection? Mayo? Yeah.
To go in the hospital
And not get an infection. And by the way, I will preface all this with that's what healthcare is, right? Who expects to go in the hospital and get an infection?
No.
Nobody, right? Guess who gets infections in the hospitals?
Everybody.
All the time, right? So to be the #1 hospital in the state from an infection perspective, I would have said Mayo, St. Joe's, Verde Valley Medical Center.
Really?
#1 hospital in the state.
And why does it have such bad reputation?
Well, I think that's new, right?
If you expect it to be bad, all you're gonna see is bad.
Reputations don't change.
No, there
Right.
is bad. There is very bad there.
There is, right? Yeah, and I'm agreeing with you, right? And I think any hospital that you go to in the country, and I don't like to say this because I've been at some of the best, there are bad things in every single hospital, right? We have to continue to improve on every single thing that we do, and we have areas that we're not good at. But I'm trying to give you guys some context of when we say something is bad, it's not all bad. There are bad areas, don't get me wrong, and I can probably talk through them. What is the #1 hospital so central line? So if you get admitted to your ICU or you have to have a central line put in, #1 hospital in the state that you don't get a central line infection. Anyone know?
Verde Valley Medical Center.
No, Flagstaff Medical Center. Risk adjusted. So that doesn't mean that you can't say like, oh, it's because they don't see as many people or they're not as sick. It's volume adjusted and risk adjusted. So #1 hospital in the state.
Nationally?
#1 hospital in the state. But what I would also say is from a central line perspective, I would bet that we are probably one of the best in the nation for central line infections. We went an entire year across both of our hospitals with no central line infections. 0. Do you know how hard that is to do in healthcare?
Should also be your goal.
100% your goal. And by the way, I say all of that to say it doesn't feel very good to be like, wow, we did really well this year. We only had 4 infections, right? I mean, think about that. Like if you're the one that got the infection, that's crazy. That's like being like, oh, I took 4 flights this year and only one of them went down. You know, I mean, so, but that's what we're talking about in healthcare, and 0 in healthcare is extremely hard to execute. Yeah, or whoever you're moderating. Yeah.
Are you having trouble recruiting people to the area? And
Yes.
so why?
So short answer.
Does housing have anything to do with it?
A little bit. So the short answer is yes. I think we're seeing more normalization of people who went to travel for these large amounts of money come back who never left the area. So we're seeing some of that. I would say where we're having trouble recruiting, if there's a reason that people aren't coming, I think again there's 2 reasons. I think there is some housing challenges or cost of housing. Although we're seeing that even normalize between, it used to be like, well, I can go to Phoenix and make the same amount of money, and guess, go look at Phoenix's real estate. It's not any better anymore. Maybe very slightly. The second one that I mentioned before is really trailing spouse and whether they can find jobs here. So I know a little bit about your family, but let's pretend your daughter works for Guardian Air and she flies on a helicopter and her husband's a school teacher and they're without a school job. It's really hard for one income earners in any scenario. We've had actually an anesthesiologist who was going to come from Michigan who didn't come because they couldn't find their spouse a second job. And they're like, geez, not that she has to work, but at the same time, if I want to live in a beautiful, she wants to work, she wants, all of those things, that becomes a really big challenge.
Schools and childcare.
Yep.
Schools are.
And we've got-
Okay.
Schools are hard. Yep.
We're gonna.
I'm good.
Whatever you got. So we're gonna cut it off here. Josh, I gotta tell you, I really appreciate not only you being here, but giving us the extra time.
Sure, of course.
And being very open to all the questions. Let's give them.
And if I'll say you guys are way better than the biggest bank. Don't tell them I said that.
I just want to ask Mark, see it confirmed a quote unquote rumor?
Yeah.
That Flagstaff is one of the top 10 trauma centers.
Please don't leave yet unless you really have to go.
Probably from a busyness perspective.
Oh, not quality.
Well, I'd have to look at quality. Our quality's good. I don't know if I would publicly say that. I don't know the answer, but I would say it's busy, for sure. And I would say, again, like programmatically, we're trying to standardize across our system, like how we do things. And anytime, actually, one of our anesthesiologists yesterday at a board meeting said this, and I thought it was fascinating, right? He said, and hopefully this will offend our physicians in the room. He's a physician, and I'm just repeating what he said. Because he said, one thing that is certain about physicians is we don't like change, and we don't like the way things currently are.
There is a national shortage
Yeah.
of specialty doctors.
Yeah.
Leading that are neurologists.
Yeah.
They actually don't have procedures, so they don't
Yeah.
make that much
Yeah.
money.
Yeah.
Primary care, if you want to improve the quality of care and reduce costs, invest in high quality primary
Yeah.
care.
Okay, everybody, so the next DORR breakfast is going to be again on the 17th in March, the third Friday. Where we will announce the topic very soon through the emails and on social media. I guarantee you it's going to be a good one. We have one in mind. We just don't want to release it now. Like a lot of things that politicians do, not releasing their ideas. But it's going to be a good one. And then in April, tentatively, we're talking about doing the breakfast about gun control and gun safety. But next month, we'll announce what that topic's going to be. Okay? Thanks for coming, everybody. Oh, wait, hold on. Our president.
I just
wants to
wanted
say a
to
few
thank
words.
everybody for coming. I want to thank Josh for being so open and transparent with us. There are a lot of answers to the questions and a lot of misinformation floating around, and having you here really helps to clarify things. I have to say, whenever I go to the center here in Sedona, I get seen right away just for my mammograms and routine things. Everybody is polite, everybody is happy, they take me quickly, and I'm in and out of there in 15 minutes. Same thing when I go for Verde Valley Medical Care. The people have been superb that I've been dealing with. Thank you for that, and keep doing all the good things you're doing. We appreciate it.
We appreciate you.